Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Today, October 3rd, 2025, we are speaking with Dr. Khalil Ghanem, a professor of medicine in the Division of Infectious Diseases at Johns Hopkins University School of Medicine. Dr. Ghanem's research focuses on the reproductive tract infections, in particular syphilis and the vaginal microbiome. He was a consultant to the Centers for Disease Control and Prevention on the development of the 2010 and 2015 Adult Syphilis Treatment Guidelines. And Dr. Ghanem has been recognized by the Johns Hopkins University School of Medicine with the W. Barry Wood Jr. Teaching Award in Preclinical Sciences and the George J. Stewart Award for Outstanding Clinical Teacher. Today, Dr. Ghanem joins us to discuss Demystifying Syphilis, Diagnosis and Treatment. Khalil, welcome to the podcast.
Thank you so much, Mike. I'm delighted to be here.
It's wonderful to have you. So, a lot to talk about. You know, there's a wonderful, interesting history of syphilis that I could spend an hour with you on, but let's just kind of talk about the recent history. What's happened since the 1990s to today?
Yeah, absolutely. It's been quite a history. In 1999, I'll remind you, the CDC actually reported the lowest rates of syphilis recorded in the United States. And at that time, they said, you know what, we are going to eliminate syphilis by 2010. So they released the plan to eliminate syphilis by 2010. Unfortunately, that was 99. And in 2000, the rates of syphilis started going up. And for 23 years, the rates of syphilis continued to go up. And it's not until 2023 when we started seeing the flattening of that curve. And as of last week, the CDC released the latest data, preliminary data still, but the latest data that suggests some good news and some not so good news. The good news is that between 2023 and 2024, the rates of syphilis have come down about 10%. The good news is that the rates of primary and secondary syphilis, those are the infectious stages of syphilis, those have come down by about 20 to 22%, which is really good news. Most of that has been driven by men. Declines in the rates in men, with some declines, but more attenuated declines in the rates in women. And so what we're seeing is that the rates in men are coming down more so than the rates in women. And unfortunately, the rates of congenital syphilis, which is really a devastating condition, the rates have actually continued to go up a bit. The slope of that increase is significantly attenuated, so that's the good news. But when you're talking about 4,000 cases of congenital syphilis every year in the United States, it is truly horrifying. And it's a black eye for public health because these cases can really be prevented simply by finding the patients that are infected and treating them appropriately. And so some good news and some bad news, but we may be starting to see changes that suggest improving rates overall.
Right. And so I think a lot of people are probably wondering, well, what was responsible? And I think it's as simple as you just said: diagnosing, screening, treatment, and some contact tracing. And that usually gets it under control. And we did that really well in the 90s and sort of fell down on the job in the last 20 years, getting better. So let's talk about screening real
quick. I'm going to interrupt you real quick and add one thing, because I know everybody's thinking about this and it's worth mentioning here, and then we can talk about it some more later. But what is the impact of DoxyPEP on these rates, right? Because remember, DoxyPEP was really introduced around 22. And the rates started coming down between 22 and 23, and the uptake of DoxyPEP has been greater in the last year, and the rates have come down even more in the last year. And just as a reminder to everyone, DoxyPEP stands for doxycycline post-exposure prophylaxis, where an individual who has an exposure is able to take 200 milligrams of doxycycline within 72 hours of a sexual exposure. And it is right now recommended in men who have sex with men and transgender women. And so in cities that have implemented DoxyPEP and where they've had significant uptake of DoxyPEP, they've been able to show significant 40 to 50% declines in the rates of early infectious syphilis. This was shown in San Francisco, in New York, in Seattle. And so the question becomes, what is the role of DoxyPEP in causing the declines that we're seeing in the last 2 years? And I suspect that DoxyPEP has had an impact and probably an important impact. That's my hypothesis. But I do think that other factors are really important as well. So it's one of the factors that's probably leading to a decline in rates of syphilis.
That's an outstanding point, and one that obviously I failed to mention. I'm glad you brought that up. The question, I guess, that comes up is, and I think the answer is pretty clear, that this is happening more among younger men who are having more frequent sexual encounters, especially perhaps with multiple partners at different times during a given period of time. And if they're armed with DoxyPEP and they use it, not only does the syphilis rate come down some, but the chlamydia rate comes down dramatically. Gonorrhea, not so much, right?
Exactly right. And in fact, this year, we've also seen rates of chlamydia come down for the second year in a row. So whether it's DoxyPEP, I think whether DoxyPEP is driving the majority of this, I'm not sure. I don't want to promote an ecological fallacy, right? We don't want to say that we're using it and so the rates are coming down because of that. But it certainly is something that is probably helping and perhaps helping significantly.
Yeah, thanks. And we'll put a link at the bottom of this podcast for some of the DoxyPEP podcasts we've done on this. Let's segue over to the more traditional ways that we've controlled syphilis, which is screening, diagnosing, treatment. So let's start with screening. Who do you screen, and what testing do you use in the clinic, and then what can you do at home?
Absolutely. So, there are lots of people that we want to screen, and we don't do such a great job with screening, to be honest. We have always targeted individuals or groups where the prevalence of syphilis is high to try and screen them so that if we find that they're infected, we can go ahead and treat them, find their partners, treat the partners, and thereby decrease the incidence of infectious syphilis and overall the prevalence of syphilis. And so, we have screened MSM, transgender women. We've also screened sexually active heterosexual men and women on an annual basis. We also screen individuals who are taking HIV PrEP. We screen individuals who are taking DoxyPEP, and we screen pregnant patients. And it's worth noting that ACOG has changed its recommendations. In the past, the recommendations used to be screen pregnant patients that come in at the first prenatal visit, and then if they are high risk, screen them again in the third trimester and at the time of delivery. But now, given the rates in women and the rates of congenital syphilis, ACOG has said screen all pregnant patients at the first visit, at 28 weeks, and at the time of delivery. So that's the latest significant change in screening. And the way we screen usually is we use one of two algorithms that are available to us. And the one that you pick doesn't make a difference. Both are perfectly reasonable. And the first algorithm is what we call the traditional algorithm, where we start with a non-treponemal antibody test called the lipoidal test, like the RPR. So we start with the RPR, and if the RPR is reactive, the lab automatically gets a treponemal antibody test to confirm that the RPR is a true positive. And that's the traditional one. And then there's a more recent one, about 10 years old, where we've been using more and more of the reverse sequence algorithm, where you start with a treponemal antibody test, and if that one is reactive, then you get a non-treponemal antibody test that provides the titer that's very important. And so either one is perfectly fine. In fact, the CDC said you can use either one and you're good to go. The reverse sequence algorithm provides you with a little bit more data that can be useful, but overall, both of them are great. What has changed recently is the availability of point of care tests and at-home tests or self-tests. And so there are now 3 of these tests, 2 point of care tests and 1 self-test or at-home test, which have been FDA cleared, and they are available. And all of these tests do the same thing. They are detecting treponemal antibodies in an individual. They are not detecting non-treponemal antibodies. You don't get an RPR titer. You only get a treponemal antibody. And as a reminder to everyone, when you get infected with syphilis, you're going to develop both treponemal and non-treponemal antibodies. And these treponemal antibodies, once you get infected with syphilis once, they're going to stay with you forever. Even though you get treated, etc., they are there essentially forever. And so if you've already been infected with syphilis before and treated, these treponemal tests are not helpful because they're going to come back positive and you probably don't have syphilis. And so they have significant limitations, but they are great because they can be done in 20 minutes at the point of care or at home by the person themselves. So it's self-testing. And so it is bringing these tests literally to the bedside or to the home. And so the advantage is access, and the home test costs about $38, so about $40 to do. But the disadvantage is, one, it has limitations like the one we just talked about. And then the other thing too is the limitation of being able to manage patients in the future. And I'm going to give you one example that happened 2 days ago. An obstetrician called me and said, Khalil, I'm seeing a patient in my clinic. She's pregnant, first prenatal visit, and I got an RPR and a treponemal antibody, and her RPR was 1 to 16, and her treponemal antibody was reactive. And I said, great, you need to treat her. I said, but wait, about a year earlier, she had had a point of care test done at her physician's office, and it was reactive, and she was treated for syphilis. At the time, they diagnosed unknown duration syphilis, and they gave her 3 doses of benzathine penicillin G. But they did not have a baseline RPR titer when they treated her. And so now she's here with a titer of 1 to 16. She's pregnant. The question is, I don't know what her titer was when she got treated. What do I do? Do I treat her again? Or do I just assume that she got treated and she didn't get infected? She says she's only had 1 partner since then, but I don't know, maybe that partner has had multiple partners. And so that's another example, right, of where these point of care tests or at-home tests can make the future management of syphilis much more complicated. So while I'm excited about these tests, I'm not sure that we have yet figured out the most effective way of deploying them in the United States at the moment.
What'd you do for that guy?
So you're stuck, right? I mean, in this situation, it's hard. The titer is not that low. It's 1 to 16. She got infected in the last year, so she clearly could have been reinfected. And so what I said was I would treat her just to be sure. Yes. I would treat her, given that the duration since the last treatment was about a year, not more. You can do 1 dose of benzathine penicillin G, but don't assume that the titers are going to come down 4-fold. Because if she hadn't been reinfected, it's entirely possible that that titer will stay at 1 to 16. The bigger question is, what would you do when the baby is born? Would you do a workup, or would you just say, most likely the titer has been stable. As long as the titer doesn't go up from the treatment, we wouldn't do anything more? That's an interesting question too. And I think it will depend on who the pediatrician is at the time.
That's a fabulous case for our segue, because now we've done the testing. The treponemal antibody is going to be positive in somebody with syphilis all the time. You've already said that. What about the RPR titer? Is there a cut point? Let's say you don't have prior information; it's a new diagnosis. Where's your threshold for treating?
Yeah, that's a really great question. And to be honest with you, when you look at the data, it's hard to find a reasonable cut point. In the literature, right, and historically, people have used 1 to 8 as that cut point, right? If the titer is less than 1 to 8, 1 to 8 or lower, then it's considered to be a low titer. And if it's higher than 1 to 8, it's considered to be a high titer. But if you look at the data, we often see patients with early syphilis who have low titers, and we sometimes see patients who have late syphilis who have high titers. So it's really tough. And at the end of the day, it's going to depend on your pretest probability for an active infection. And your pretest probability is going to depend on the history. And I think here, the history, getting a good history from the patient is probably the best thing. If the patient is comfortable and is willing to answer questions truthfully, then and if they say, I haven't had exposure since the last time I was treated, I think I would have a lower threshold to treat. But it's so tough. Social desirability bias is such an important bias that drives answers to questions, right? It's patients wanting to tell you what they think you want to hear. And it's a normal thing. We all do it, right? You get invited to a dinner party and, the meal is not great. And the person who made the meal asks you, hey, how was the meal? Of course, you're going to say, it was wonderful. Thank you for having me. And the same thing happens when you're asking patients who are standing in front of you. Have you had sex since the last time I saw you? Did you use a condom? The answers are always no. And if I did, yes, I used a condom all the time. And so I think part of it is understanding human nature and trying to create an environment where somebody is able to give you the correct answer, and that way you're able to make the right decision.
Yeah, in that dinner scenario, you could just channel your inner Larry David and go, pretty good. It wasn't great, pretty good. So now I'm wondering whether the new changes, the new data on treatment might affect your threshold, because we used to use one dose, right, for early syphilis. If it was more intermediate or later, you'd use 3 doses of benzathine. So new data?
So I think the new data essentially have confirmed what we have been doing and what the CDC has said we should do. So remember, in the early part of the HIV epidemic, when a patient came in with syphilis, there was a lot of controversy about how we should treat somebody with early syphilis. Should we just give them 1 dose of benzathine penicillin G, or should we give them 3 doses like we would treat somebody with latent syphilis? And there was a lot of controversy, and some people felt strongly that we should use 3. Some people felt strongly that we should use 1. And there had been, over the years, an accumulation of observational data that essentially showed us that 1 dose was probably just as good as 3 doses. And yet there were still some questions. And so finally, an NIH-funded study was done where they compared 1 dose to 3 doses of benzathine penicillin G for early syphilis, primary, secondary, early, latent. And this study included a fair number of people living with HIV. And so what they found was exactly what the CDC had suggested, that there was really no difference in serological outcomes in the RPR titers coming down between 1 dose and 3 doses. So I think what this study has finally put to rest is the question question, how should we treat early syphilis, particularly among people living with HIV? And the answer is 1 dose of benzathine penicillin G is all you need to treat somebody with early syphilis, whether they have HIV or not. And 3 doses is what we're normally using to treat latent syphilis or unknown duration.
So one of the interesting things that also happens that confounds us a little bit, you have somebody who's been using DoxyPEP, and they come in and their titers bumped a little bit. Is that new infection? How do we interpret that?
Yeah, that's a great, syphilis has always been challenging, right? But in the era of DoxyPEP and in the era of point of care tests, there are really some new challenges that we're having to face. And this challenge is the DoxyPEP challenge. There was a great paper or a great presentation that was presented by Chase Cannon from the University of Washington at the ISS-TDR meeting in Montreal in July, just last month or 2 months ago. And Chase essentially looked at individuals who were not on DoxyPEP and were diagnosed with syphilis, and individuals who were on DoxyPEP and were diagnosed with syphilis. Remember, DoxyPEP reduces the incidence of syphilis by about 70%, up to 80%. But about 20 to 30% of patients who are taking doxycycline intermittently are still getting infected with syphilis and with chlamydia. And so what happens to these individuals that are on DoxyPEP, taking doxycycline intermittently? What happens to their titers when they get reinfected while on DoxyPEP? And what he showed was those individuals who were on DoxyPEP and who got infected with syphilis had fewer clinical manifestations. So they had fewer signs and symptoms of syphilis, early syphilis, and their titers were actually 4-fold lower than comparable stages, the titer of individuals in comparable stages of syphilis who were not on DoxyPEP. So in other words, DoxyPEP can mask an increase in titers. It can also mask the clinical manifestations of syphilis. So what that means is now clinicians who are taking care of patients who essentially are taking DoxyPEP, they have to be really careful in how they interpret serological testing for syphilis, and also have to be aware that the clinical manifestations of early syphilis may be much less pronounced. So in other words, if I see a patient who's on DoxyPEP who has an atypical rash or whose titers go up a little bit and they have the appropriate history of exposure, I think I may have a lower threshold to treat those patients for early syphilis than to just observe them. And so, again, the point of care tests and the DoxyPEP era have provided new challenges for us when we're trying to diagnose and manage patients with syphilis.
But a bit of a better solution that it's only one shot in that setting. And I think that's a real help to all of us, for sure. A lot of us, though, in clinic are finding that there's a shortage sometimes of bicillin. And just to put it out there, I think what most people do is doxy twice a day for a period of time. You'll have to tell me 14 days or something.
Yes.
But there's also data out of Japan where they use amoxicillin with probenecid, and to me, by my eye, that looks roughly the same. Yet in the U.S., we tend to lean towards doxy. What do you recommend?
Yeah, so the doxycycline data, even though they're still limited, the doxycycline data are stronger. So in somebody who can take doxycycline and does not have access to penicillin, remember, we always love penicillin. In every stage of syphilis, we want to try to use penicillin whenever we can. But if we can't, if we don't have access to penicillin, if somebody is allergic to penicillin, as long as they're not pregnant, doxycycline, the data supporting doxycycline are stronger than the amoxicillin data. And so we recommend doxycycline 100 twice a day for 14 days for early syphilis or for 28 days for latent syphilis. It's an excellent drug, and the data are fairly consistent, even though it's not a lot of randomized trial. We're talking about observational data. On the other hand, the study that you mentioned from Japan using amoxicillin and probenecid was the data were much more limited, and it showed excellent efficacy for early syphilis, but the data on late syphilis were not quite as clear. And so because of the very limited data on amoxicillin, the recommendation by the CDC is when you can't use penicillin, go ahead and use doxycycline. And for pregnant patients, the only thing you can do is treat them with penicillin. And so you have to admit the patient, if they're allergic, desensitize them. Indeed, the ASTDA just released a paper a few months back trying to look at all the data for alternatives to penicillin in pregnancy. And what they found, we got nothing. And so essentially whenever there's a shortage of penicillin, we've had 2 shortages in the last 2 years of benzathine penicillin. What you need to do is essentially save the benzathine penicillin, the stock that you have, and treat individuals who are pregnant and treat everybody else who's not pregnant, all other adults, using doxycycline, which is probably the preferred alternative regimen.
So, as I anticipated, our time has flown by, but we have covered a lot. We've talked about the increasing rise with some better news, the still consistent problem with congenital syphilis, and I think we should be leaning towards, as you said, testing everyone through stages of pregnancy. That should help a lot.
Yes.
Having a pretty quick trigger to treat if there's any uncertainty, especially among a pregnant woman. The big news about the new one-time treatment with bicillin for those folks who are in earlier secondary syphilis, and that's really big news. It makes life easier. Also, the testing algorithms pick your poison in a way, but I think a lot of us are using the reflex one that
Yep.
works pretty well, but either one would work. And the home testing, which is a real addition, plus DoxyPEP. We covered all that. That's awesome. What do you think are the challenges we should be addressing in the next 3 to 5 years?
Yeah, I think that there are a couple of challenges that I think are worth addressing. The most pressing challenge is to find alternatives to benzathine penicillin during pregnancy. I think this is a gap that we need to fill. The good news is I believe the Gates Foundation has funded a trial overseas to try alternative regimens to penicillin, benzathine penicillin G, for treatment during pregnancy. So that's one very important area. I think there are other things that are coming down the pipeline that are exciting. There is a study on linezolid for early syphilis. The authors from Spain published the first arm that they looked at, which was using linezolid at half the standard dose, so 600 milligrams once a day instead of twice a day, and they used it for half the duration that is standard. Instead of 10 days, they used it for 5 days. And so they used half the dose at half the duration, and needless to say, that didn't work. About a 30% failure rate for that regimen. But now they have another arm where they're using twice a day linezolid for 10 days. And those data are going to be available in the next year. And so that's exciting. Stay tuned for those data. There's also some interest in looking at cefixime for the treatment, oral cefixime for the treatment of early syphilis. And so there is some energy there to try and get a trial ongoing. And the last thing I'll tell you is that there is a funded trial by the NIH, both the IDCRC and HPTN, looking at oral high-dose doxycycline for the treatment of neurosyphilis, ocular syphilis, and otic syphilis. We use doxycycline high dose to treat neuro-Lyme disease, neuroborreliosis. And so we have some preliminary data to suggest that high-dose doxy is quite effective at treating neurosyphilis. So that trial is going to start recruiting most likely in the winter and go on for about 3 years. So those are the things that are coming down the pipeline. I think we need better diagnostics and better treatment options, particularly in pregnancy.
Fabulous. I think everyone can see why you've won the teaching awards at Johns Hopkins. That you are just a natural teacher, and you just also primed me for coming back to you at another time where we can talk about CNS manifestations. That's a whole nother barrel of fish, but it's very important, and a lot of it shows is some confusion, but hopefully good data coming up. Khalil, thank you so much for being with us. This has been fabulous.
Thank you for the invite. It was my pleasure.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed on this podcast do not necessarily reflect the opinions of the IAS-USA and its affiliates. And the viewpoints of the individuals on this podcast do not necessarily represent the viewpoints of their institutions. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode. Thanks for listening.